56 years old, female, and last January weight loss of 5 kilos with diabetes and abdominal pain. CT scan showed a pancreatic mass of the head with MPD dilation and peripancreatic lymph nodes, but no vascular involvement. Now we'll do US with Sonovil and FNA.
We are with the probe in the second part of the duodenum. We have here the mesenteric vessels, the vein and the artery below. We gently pull back the scope. Check for the head of the pancreas. And immediately we can see here a focal solid lesion that is hypoechoic. We can measure the lesion.
Okay.
The lesion seems to have some irregular borders. It's more or less 2 centimeters, 2.5. Okay.
No, but this is a very nice case to see how AUS can really improve and provide a lot of information when you're facing a pancreatic solid lesion in terms not only for the detection, that we know for sure that AUS is the best technique for the detection of solid pancreatic lesions, mainly for small lesions, but also for vascular staging.
Yes.
And there is a big discussion with the radiologists whether multi-detector CT scan is better or worse to AUS. I think, honestly, they are complementary. But probably AUS, of course, it all depends in hands as well as CT scan, can really provide us with very, very useful and very, very nice information about the relationship between the big vessels that are going to determine the management of pancreatic cancer.
So when you have a solid lesion of the head of the pancreas, it's really important to check for any lymphadenopathy between aorta and cava. This is the cava, and this is the aorta. Otherwise, if there are any pathologic lymph nodes, this is a metastatic disease. But I don't see any.
No. So it's also very important when you are just staging pancreatic cancer is not only to look at the lesion, but also, as Mara is highlighting, you need to check for lymph nodes, because at the end, the staging of pancreatic cancer is not really based on TNM classification, but more in the classification of whether it's resectable, borderline, locally advanced, or metastatic disease, because there's some issues with TNM that you can have a T3 non-resectable lesion and you can have a T3 directly resectable lesion. That's why there's a little change in the staging of pancreatic cancer, more linked to the final management of the lesions.
Yeah. Looking at the vessels, I would say that superior mesenteric artery is free. Yes. We can follow it.
And again, it's also important that this is a dynamic exploration. I mean, AUS is not there to take a single picture, because for sure Mara can take a picture saying that it's absolutely infiltrated everything, but you need to see the dynamic image, the behavior of the vessels related to the tumor.
And something different about the superior mesenteric vessel close to the portal vein. I would say that in this area, perhaps there is.
Here.
Yes. It's really close to the vein, to the portal vein.
So some sort of irregularity there is not a well-defined separation between both. I mean, there is very nice to see the flow, because it provides information that there is flow inside of the vessel, which is very nice. But this is more, maybe there's some kind of, probably a little bit more than a contact. Maybe a slight infiltration. Maybe we're speaking, Mara, you think on a borderline? Probably?
Yeah, probably it's a borderline. We catch that with the elastography as well for any pathologic infiltration, just to check the lesion from the stomach. So we have the portal vein here, then superior mesenteric vein. This is the pancreatic duct that is a little bit dilated by the lesion.
And these pictures that Mara is showing us are very important, because there's always been some complaint about the evaluation of pancreatic head based on AUS when you have not access to the duodenum, or whether you have a patient with a Billroth 2 resection. So it's okay, you cannot evaluate pancreatic head in those cases. Really, today is not true, because with these high-definition scopes, it's very easy to see the head of the pancreas from the stomach in a very high quality, and you can easily do a very, very nice staging and very, very nice evaluation of pancreatic head just with the new scopes and with the new systems that we have available. We're working with the Hitachi Astendos. There's an amazing images that we are able to obtain.
It's always important to see from both sides.
Yes.
You look for the circumferential involvement. It's very important to see the vessel from both sides. So you can have only no involvement from this side, but you can look from the other.
Yes.
So you're going to have to pass on what Paolo says.
Paolo says is that it's very important to make the staging from both sides. I mean, if you can see the lesion from the head of from the duodenum, it's perfect. But the image that you have from the stomach is complementary to the other one. So you can really have a very nice almost 360 evaluation, because we know to define resectability or locally advanced, it depends on the degree of infiltration and the length of infiltration.
Even from the bulb, if you see, we can perfectly see the portal vein here, with the superior mesenteric vein, the splenic vein, the pancreatic duct that is a little bit dilated from the lesion, and for sure we can check even for the superior mesenteric artery.
Yeah.
So we are able to see...
Julio, people say
Yes.
that the weakness of the EUS is the SMA, to the left side of the SMA. What's your view on that?
Okay, I think at the end depends on I mean, probably one of the most tricky things to do in diagnostic AUS is to stage pancreatic cancer. But at the end, it's a matter of training. If you get trained and you do a nice number of procedures, SMA is quite easy to see based on AUS. And if you are trained to stage, I mean, you can be very, very accurate. And both from the duodenum and both from the stomach, you can very well define and depict the complete SMA and really can perform a perfect staging of both superior mesenteric artery and superior mesenteric vein. So I think it's just a matter of train to do procedures and be taught by advanced endoscopists. But honestly, I think by train you can really do a perfect staging even in SMA.
Okay.
So what do you think?
We can check with Sonoview, I think. Just 1 minute. No?
So we've been seeing, at least Mara and us together, we're working on a cystic lesion for Sonoview. But I think it's nice to see how the behavior of pancreatic solid lesions with Sonoview, because according to the pattern, we can have a nice approach to define a diagnosis. Okay. So we're going to move to the Sonoview. Okay. So we'll reduce the focus. Okay. So from the technical point of view, remember it's very important to place the focus below the lesion. Try to have the lesion in the center of the image, and remember about the two phases that we have.
We can inject. Yeah.
Because we have the arterial phase, which is the beginning.
Start with injection. Yes.
Okay. So first 30 seconds is the arterial phase, and the second part, from the 30 seconds is the venous phase, and it's important to see the evaluation on the whole minute.
Okay.
It's very nice. Okay, you can easily see there is no enhancement in the venous phase, and it's quite often to see some arteries in the arterial phase, small arteries. But the most important thing is the washout. There is no uptake of contrast in the venous phase for pancreatic adenocarcinoma.
Okay.
So we have also Christoph, if you want to...
Nothing to add.
I mean, we know from the literature and a lot of studies that have been conducted about what is the meaning of an hypovascular lesion. The probability of adenocarcinoma in this case is as high as 89 to 90%. And if you combine this hypovascular lesion with a blue heart pattern with the elastography, the probability of adenocarcinoma can be as high as 95, 96%. Well, Mark is.
Yeah.
Yes.
we think so.
It's for biopsy, no?
Well, we can discuss about the. I mean, we used to go for biopsy
Yeah.
because the
Of
oncologists
course.
always want the biopsy.
We
Ah,
still need. We
But
still need the biopsy.
there is something funny for the oncologist, is that they need the histology, but sometimes with the PET scan, which is positive, they don't need histology. And
So yes, it's true. I mean, at the end, it depends on the protocol you discuss with your oncologist. But it's true that in these cases, the probability of pancreatic adenocarcinoma is very, very high.
Yeah.
but we need, of course.
But it's a borderline, so it's probably a candidate for neoadjuvant therapy. So we need a.
Okay.
If they are going to send the patient for surgery or do neoadjuvant.
Paolo is sending me a question for the audience. Is with this
On y va.
case,
Vous
would
y
you
allez?
send the patient directly for surgery, or would you recommend neoadjuvant therapy?
I think a lot of people will be offering neoadjuvant
Neoadjuvant therapy.
more easily resectable, probably.
Okay.
Is the resection.
Okay, now we are moving for the biopsy. I'm using a 20 gauge needle Procore.
What needle are you using, Ma?
20 gauge needle, a Procore needle. We
Do
can
you
nicely
leave
use
the
the.
flow on?
No, absolutely not.
Because it makes me very nervous with my finger with the flow on.
So,
This needle is more flexible, right?
yeah, absolutely yes. You see the sheet of the needle coming out. And now we try to puncture the lesion. We pull back a little bit more the scope to have a best.
Can you hear us in the audience?
I
Yes?
have a question why we have chosen the audience, why we have chosen a 20 gauge rather than even a 25 or a standard 22.
I think in this case, because I know that here the pathologists prefer the histology, so the microcore. Otherwise, at home, I usually use the 25 gauge needle because of the on-site evaluation. But even in this case, perhaps for the pathology experience, I think that they prefer an isolation of a microcore.
But that's another point that we need to change in the future because there is now more and more personalized medicine, and we more and more need to have better and bigger samples to direct oncology.
Okay.
So probably there is a trend to use to obtain samples that are suitable for molecular testing, molecular analysis.
Okay, you can see the needle inside the lesion, and we can even see the small window of the tip of the needle here. And now we can remove the stylet.
Funny how you like to have the image upside. I mean, wrong. Very interesting technique.
Okay, thank you. We apply the suction now. Okay. I just do many movements forward and back. Okay, and I think we have done. Let's check for the
Recheck
material. Yeah.
Please, can you show the specimen to the camera?
Well, I will try to answer this. I always try to go for core, but at the end depends on your pathologist whether you have rows or you do not have rows. If you have rows, at the end do what your pathologist wants you to do. But if you do not have rows, it's better to go for cytolite directly.
Another passes, no?
There is a
small
core
core,
biopsy.
yeah,
Yes, there is
but
not a small, a nice core.